This presentation is on central cord syndrome. Central cord syndrome is the most common incomplete spinal cord injury syndrome. It presents as an incomplete tetraplegia, so the patient maintains some motor and sensory function below the level of the injury. The characteristic presentation of central cord syndrome, or CCS, is that it's symmetrical weakness that's greater in the upper extremities than in the lower extremities, which I'll talk more about in the next slide. It most commonly occurs due to a traumatic hyperextension injury at the cervical spine. And as we know, the cervical spine is the most vulnerable part of the spine because it's got a lot of mobility and isn't protected by very many bony or soft tissue structures. Because of this, the hyperextension injuries are very dangerous to the spinal cord in the cervical spine. So what happens in the cervical spine during the hyperextension that creates a spinal cord syndrome is that the spinal cord is pinched between the ligamentum flavum, which is pointed out there in that picture. It's right behind the spinal cord in the canal, and that pinches the spinal cord along with the protruding anterior disc in the front of the spinal cord, or if there's an osteophyte. So there's actually some debate at what's actually occurring in the spinal cord when this is happening. The research has shown in the past that they thought it was because there was a contusion to the spinal cord causing a stasis of the axoplasmic flow, and then there was an edematous injury. But now newer research has been, which was done on cadavers, has been shown that it's actually most likely caused by bleeding in the spinal cord, creating a hematoma, therefore disrupting the axonal information of the spinal cord. And then there's also some lateral column injury or disruption in the lateral columns at the level of the injury. So how would this present? So the clinical presentation of central cord syndrome is that it's a symmetrical incomplete quadriplegia, that should say tetraplegia, and the weakness is more significant in the upper extremities than in the lower extremities. So thinking about the spinal cord, what region of the cord would have to be most affected for this clinical presentation? Hopefully, you realize that the name completely gives it away, and it is in fact the central, most medial part of the spinal cord. Here's a picture demonstrating that the hyperextension actually damages that middle region. So thinking about what we learned previously in our neuro classes about the pattern of lamination in the spinal cord, it makes sense that the central region would affect the arms because lateral to medial in the spinal cord, the sacral tracts are most lateral, and then lumbar, then thoracic, then cervical. So, like I said, the damage is in that red region there, the most medial. It makes sense that in this condition, the most affected extremities are the arms and especially the hands. The patient will have actually flaccid paralysis of their upper extremities initially. The other symptoms that the patient will have is that depending on the extent of the damage in that middle region of the spinal cord, they will have some lower extremity weakness. You can see in that lower picture that there's the ability for the damage to extend out into the lower extremity regions and even into the sacral regions, which is why they can have possible bladder, bowel, and sexual dysfunction. So they also have variable amounts of sensory loss because of the effect on the anterolateral and DCML tracts that are affected by the damage. And again, this is going to present as varying levels of sensory loss, of pain, temperature, as well as light touch and proprioception. So the population that this typically affects is generally more of the older adult population, and it most usually affects patients who already have a cervical spondylosis, which means that their cervical spine is already not it's not intact, as well as a younger person. And generally, well, there's always a mechanism of injury for patients who have central cord syndrome. Most common, it's due to a fall, especially in the elderly if they have that spondylosis and their cervical spine has already lost some integrity. The fall just makes the syndrome even more common because they don't have the strength of that spinal cord or the vertebral column to protect their spinal cord. Otherwise, it can be caused by motor vehicle accidents, diving injuries, sports, or assaults. It can happen in any age from 18 is the youngest I saw in the research, up to late 70s, 80s, and 90s. So initial treatment is done initially when they are called into the hospital, and the biggest thing is to prevent and limit further neurological damage. So this can be done surgically or non-surgically, but first and foremost, they're always going to immobilize the patient, especially their neck, and put them on bed rest and in a neck brace, like Snooki's showing us. And then they can go down either two paths of a surgical treatment or a non-surgical treatment. Non-surgical is, again, that bed rest and a neck brace, or it could even be a halo, depending on how severe it is. And then they'd put them on medication such as steroids to decrease the possible inflammation that's occurring at the spinal cord, at the cervical spinal cord. And then for surgical interventions, there's a few reasons that they would choose surgical interventions. They do an MRI or a myelographic evaluation or CT scan and decide if the spinal cord is enough that they need to go in there and surgically decompress it. Or they would check if the patient has a very unstable neck or a clear fracture or a subluxation, possibly a disc herniation. Then they're going to go in there either anteriorly or posteriorly and decompress the spine or stabilize the unstable fracture. What they do include in this decision of surgical versus non-surgical is the risk that is involved with surgery. If the patient's elderly and has a lot of different issues going on, they likely won't do surgery. And they've also found at the 2-year mark, when the patient, 2-year marks after the injury, the patient's surgical and non-surgical are generally the same. Surgery only helps initially increase function. So the prognosis of central cord syndrome is generally favorable. It depends on a few different factors, but overall, patients regain quite a bit of function. So age is the biggest contributing factor. So it's generally a bimodal distribution of recovery. So 50 years is really that benchmark. If you're younger than 50 years, you have a 97% chance of regaining function in your upper extremities. And if you're older than 50 years, you have a 41% chance. So it's a pretty significant difference. The other factors that play a part in prognosis is the severity of the injury. If it was due to a fall or if it was due to a really bad diving accident, it's obviously going to have a bit of a different influence on the prognosis. And then again, the cause of the injury, whether it was due to lysis and slipping because of the fall, or if it was really bad hyperextension. And also pre-existing conditions play a factor, especially in patients that are elderly. If they already have cervical stenosis or calcification of the ligamentum flavum or spondylitic pathology. And then the pattern of recovery for central cord syndrome is that the recovery starts most distally and comes up proximally. So you get the lower extremity strength and sensation back, and then research shows that about 6 months you get bladder function back. Before that, they generally have to have a catheter. And then very slowly, the upper extremity strength will come back. And then finally hands, but hands remain the most limited and may not come back at all. So a recent study found that 1/2 to 2/3 of patients with central cord syndrome actually experience the level of motor recovery they will have in the first year within the first 2 months of recovery. So the first 2 months are critical. Most patients have about a 30-day hospital stay after this diagnosis, and then a couple months of rehab, inpatient, and then outpatient. Okay. So recovery and treatment is initially focused on preventing any spinal cord injury associated morbidities that are listed, so making sure the patient stays safe while they're in the hospital. And then it's to focus on early mobilization, especially maintaining range of motion, especially of the upper extremities because they have no strength. And then psychological rehab is really important because these patients can have a high level of anxiety and helplessness because if they can't use their upper extremities, they're heavily reliant on a caregiver. And then physical therapy or physical rehab comes next. And hopefully you have an idea of how important physical therapy is for these. There's a lot that physical therapy can do. On the left, there's listed impairments, functional limitations, and some disabilities, and then the interventions that we can do to help these patients. The main goal is to preserve the range of motion, prevent contractures, preserve what they have, and preserve the strength that they have. So like I said before, lower extremity strength comes back first, and lower extremity sensation comes back first, but it doesn't come back it doesn't come back right away. So they'll need some help with strengthening the trunk so that they can perform transfers and mobility, and then eventually get back to gait and stepping. And initially using a platform walker might be because they won't have that trunk strength or lower extremity strength. So having something to lean on to would be helpful. And then as their recovery progresses and they start to regain some upper extremity strength, then you can focus on strengthening the upper extremities, using some functional e-stim. Research has shown that that's really effective. Also taping. Some patients have subluxed shoulders, and so taping can be really helpful. And then one of the biggest things is that they're very limited functionally. So they may never regain that hand strength. That's why using upper extremity assistive devices can be incredibly helpful for regaining their independence. So either consulting an OT about that or researching it on your own can be really helpful for these patients because they'll need those devices if they don't regain the strength. Research also shows that for the patients that are younger than 50, there's not 100% return to work. Many of them remain disabled. Between 50 and 70 return to work. And then also, because it is a spinal cord injury, they do have a chance of having autonomic dysreflexia. So make sure to pay attention to the signs of that when you're working with these patients in the earlier stages of their recovery. Okay, in summary, central cord syndrome is an injury to the central region of the spinal cord. It results in upper extremity weakness that is more significant than lower extremity weakness due to where the damage is. It affects sensation and can also affect bowel and bladder function depending on the severity of the damage. They'll regain function from their lower extremities to their bladder to their arms and their hands, but they may not get everything back in their hands. The younger the patient is, the more likely they have a chance of recovering, and then the less traumatic the injury, the better as well. And it can take over 2 years to regain function. PT is definitely indicated to maintain that range of motion right away, and then to continually increase strength of the lower extremities and upper extremities as the patient continues to recover.